Hello and welcome to Pulse Check with Archer Nursing, where nursing comes to life. In this podcast, you give us 15 minutes of your day, and we'll take one complicated nursing topic and make it easy. Ready for nursing to be fun? I'm Morgan, and today we're diving into Abruptio Placentae, or a placental abruption. This is a fast, scary obstetric emergency where the placenta suddenly separates from the uterine wall. Ready? Let's jump in with our practice question. As always, tuck away what you think the right answer is, and we'll circle back to the correct answer at the end. So we have a nurse caring for a 35-week pregnant client who presents to the emergency department with sudden onset of severe abdominal pain and vaginal bleeding following a minor car accident. The client is very anxious. The uterus is firm and board-like on palpation, and she reports that the pain is constant and will not let up. Fetal heart tones show recurrent late decelerations. Which nursing action is the priority? We have A, starting an oxytocin infusion to increase the strength of contractions. B, placing the client in high Fowlers to reduce uterine pressure. C, inserting a Foley to monitor hourly urine output. Or D, notifying the provider and preparing for an emergency delivery. So again, think about your answer, and we'll come back after we unpack what's actually going on in there. To understand Abruptio Placentae, we really have to get clear on the placenta. How's it attached and how mom and baby share blood? Big picture, think about the uterus as a big muscular house, and the placenta is that baby's VIP room that is stuck along one wall. The placenta attaches to the uterus, that's the wall where we have this connection point, and it has really millions of tiny little, I'll call them Velcro points, where maternal blood flows in and fetal blood out. Mom's and baby's blood is not actually mixing per se, but they get really close so that oxygen and nutrients can cross over, kind of like we're passing notes through the wall here. And as long as the placenta is flat and snug against that uterine wall, the baby is going to get a steady supply of oxygen. Now, in Abruptio Placentae, or that placental abruption, we get premature separation of a normally implanted placenta from the uterine wall. Now, we do want the placenta to detach, but that should be after delivery of the fetus. If it attaches before, it's a placental abruption. Instead of the placenta staying glued to the uterus, part or all of it tears away early, and that disrupts the blood flow. Now, what can cause this to happen? Most of the time, it's a shearing force or fragile blood vessels. So that could be caused by having chronic high blood pressure that can make those vessels more friable. We could have a trauma like a car accident, a fall, unfortunately, IPV or intimate partner violence. There could also be the sudden loss of uterine volume. So say we have polyhydramnios with tons and tons of fluid. All of a sudden we get rupture of membranes and we just lose a ton of fluid. That loss of uterine volume can be the shearing force that separates the placenta from the uterus prematurely. Any of those things, they can cause tears in those vessels where the placenta is attached, and that leads to bleeding that separates the placenta from the uterus. So we used to have it really snug, that wall right there, so we could get gas exchange. We get shearing, bleeding, it separates farther and further. Less contact means we have less ability to pass oxygen over to the baby. The more the placenta separates, the less surface area we have available for gas exchange. So with less gas exchange, here's what shows up. For baby, late decels and fetal distress. They are not going to look good on the monitor because they are not getting oxygen. For the mom, uterine muscles are going to respond by clamping down to try and stop that bleeding. Therefore, she gets a firm, rigid, board-like abdomen. Contractions are going to feel like one long contraction, very, very painful as that uterus clamps down. But as much as it clamps down, it's not going to be able to stop this bleeding. There will be massive bleeding, and we can get that in one of two flavors: revealed or concealed, which is exactly what it sounds like. Revealed, that separates, we get a massive amount of painful dark red bleeding. Concealed, separates and it stays internal. So we don't actually externally see the bleeding, but there are massive internal losses. And all that bleeding, whether it's revealed or concealed, is going to lead to super serious maternal consequences. Because as it continues, mom loses more intravascular volume, becomes tachycardic to compensate, hypotensive, and eventually will go into hypovolemic shock. Additionally, the damaged placenta and all that pooled blood, it's releasing a lot of clotting factors, which can trigger DIC, disseminated intravascular coagulation. So, big picture here, we have a placental abruption. The placenta rips, it separates from the uterus. We get bleeding that leads to a rigid, painful uterus. Baby's not getting oxygen, they're hypoxic, looking real bad on the monitor. And we get maternal bleeding, leading to potential hypovolemic shock and DIC. This is a scary emergency, and I think important to say, a totally different vibe than our placenta previa. Just reminding you from our previous episode there, we had painless bleeding. We had a soft uterus versus in this abruption, it is very painful. We have a board-like abdomen. Those are big trigger words that should make you think abruption. But let's talk through a case so that we make sure it sticks. You are working in L&D and you get a call from the good old emergency department that we've got a 32-year-old. She's 36 weeks pregnant. She's bleeding in severe pain, and we're on the way up. We're not waiting. She rolls up to you and she is pale, tachypnic, clutching at her belly, saying something is wrong. It hurts and it will not stop. That's your first clue right there. It hurts and it will not stop is not normal labor. There should be breaks between contractions, even if they are short breaks. If it is one long 10 out of 10 pain, something is up. So let's check out her history here. You know, she's 36 weeks pregnant. We go in here and we see chronic hypertension. She says she's felt tightening and pressure all day. And then suddenly there was a gush of dark red blood. All right, that makes the hair on the back of my head stand up. Dark red blood, tight pressure. All of this is making me think abruption. What do her vitals look like? Heart rate of 118, BP of 94/58. Not bad, but she has a history of hypertension. So is that low for her? Sounds like it. Her respiratories are at 28 and she is pale and anxious. Palpate that abdomen. On assessment, it is rock hard. It is not soft and resting between contractions. We have board-like abdomen. That's a buzzword on the NCLEX for abruption. Rigid board-like abdomen. What's the baby look like on the monitor? Baseline 170. That's tachycardic. Minimal variability. I don't like that. And we're seeing late decels. What's going on? This baby is in distress. They are not getting enough oxygen. Paired with a rigid board-like abdomen, decreasing blood pressure, and a gush of dark red blood, this mom is bleeding because her placenta has separated from the uterus. Classic presentation of placental abruption. This is a true obstetric emergency, and this is how it presents. They come into the ED and you move fast, okay? What's our priority? Call for help. Get that baby on the monitor. Hit the emergency bell. Let OB know. We need everyone in the room because both baby and mom are in trouble here. Now, positioning, what you can do as the nurse is pop her on her left side. That's going to take pressure off the vena cava and improve blood flow to the uterus and placenta. Better venous return, better cardiac output, more blood, and therefore oxygen to baby. It ain't gonna fix it. That's not gonna do the whole trick, but that's gonna optimize perfusion while we get our emergency handled here. Okay, so get her on her left side, and then number 3, pop some IVs and get labs while you're at it. 2 large bore IVs. These are going to need to be 16, 18 gauge. Labs, we're going to need a CBC, type and cross, coag panel, and fibrinogen at a bare minimum. A lot of times we're going to send a rainbow where we just send everything. But specifically, we need to make sure we have a CBC and a type and cross because we might have to follow a massive transfusion protocol or MTP as she is losing so much blood and potentially going into hypovolemic shock. Why do we need coags and fibrinogen? Because we're worried about DIC. That would show up with a low fibrinogen, a prolonged PT, PTT, and low platelets. We'll see that on this CBC. So labs and get your IVs. Gotta have those large bore IVs in there because our next step is fluids. This needs to be an isotonic fluid so it goes in the vessel and stays in the vessel. That's going to support blood pressure and improve perfusion. Again, just like with positioning, is giving her fluids going to fix this? Absolutely not. But it is supporting the perfusion we do have while we work on ultimately resolving the issue. Another thing we can do is put her on oxygen. Go ahead and do 10 liters via a non-rebreather to just maximize how much oxygen we can get in there. Remember, if the placenta is tearing apart from the uterus, we have less surface area for gas exchange. Every little bit of oxygen is going to matter here. So the more we can get better perfusion and get more oxygen in, the better baby's going to do. One thing you are not going to do is a vaginal exam. Big no. We don't have time for a routine cervical exam. It's not going to give us more information. And with active bleeding, it could actually worsen things. We only do these cervical checks when they're ordered and when it's clearly safe and necessary. This is a time where it is not. So far, we're getting more people in the room and we are optimizing perfusion. Left side, fluids, oxygen, we're sending off the labs, but ultimately only one thing is going to resolve this issue, and that's an emergency delivery, okay? So in this case, OB comes in, takes one look at that fetal strip, minimal variability, tachycardic, late decels, rigid board-like abdomen. We are already walking to the OR. Baby's in distress. Mom is showing early signs of hemodynamic instability with that blood pressure. She's not fully dilated and ready to push out that baby, so we are going to the operating room for both of their safety, okay? We're going to roll right back there, deliver that baby, get them resuscitated, deliver that placenta, and control the bleeding. That is the only thing that will resolve a placental abruption delivery. So with all that being said, let's bring it back into our practice question now to see if you can get to the right answer and understand why. You're caring for a 35-week pregnant client who presents with sudden onset of severe abdominal pain and vaginal bleeding following a minor car accident. The client's very anxious, the uterus is firm and board-like, and she reports the pain is constant. Fetal heart tones show recurrent late decels. What is your priority? So this is exactly the client of the case we just walked through. Which of these actions do you prioritize? Starting oxytocin to increase the strength of contractions, placing them in high Fowlers to reduce uterine pressure, inserting a Foley to monitor urine output, or D, notifying the provider to prepare for emergency delivery. We've got a placental abruption suspected. What is our priority? You guys know it is D. We are preparing for that emergency delivery. This presentation is very classic for an abruption. The severe abdominal pain, the dark vaginal bleeding, and especially that firm board-like uterus. We also see that the baby's in distress with those late decels. That means they're not getting enough oxygen. Time to get the baby delivered. A, giving oxytocin is absolutely not indicated. With an abruption, that uterus is already hypertonic and clamped down. Oxytocin's gonna make it worse. B, putting them in high Fowlers is another no-no. That would decrease venous return and could worsen maternal hypotension. We want to go left lateral to increase blood flow to that placenta. Would we insert a Foley? I mean, sure, we can pop a Foley in there, but it is by no means going to fix anything. It is not a priority. This baby's in distress. We need to get them to the operating room and deliver that baby. So those are your big takeaways. I want to end it by once again comparing to that placenta previa, because I bet you'll see this on the exam. With that placenta previa, see our prior episode, it is painless. We have bright red bleeding and a soft uterus. What we just saw was an abruption. It was painful, dark red bleeding, and we had a board-like uterus. You need to be able to recognize these signs, the pain, the rigidity, the bleeding. Know that this is an emergency, and most importantly, prioritize calling for help to prepare for that emergency delivery. right, future nurses, that is a wrap. If you found this pod helpful, I'd love to continue supporting your nursing journey through nursing school, the NCLEX, continuing ed, and beyond. Archer Nursing has you covered with on-demand video lectures, high-yield question banks, live case study reviews, and so much more. We want to help you master tough concepts and make it fun. So join us over at archerreview.com. Follow us on socials at Archer Nursing for more free nursing tips and study resources. Thanks for tuning in to Pulse Check with Archer Nursing. I'm Dr. Morgan Taylor, and I'll see you back next time.